looking at specifically the comparison of blood, saliva, urine. What are they as various mediums, looking at what their advantages and disadvantages are. And we'll delve into the whole idea of urine. And in the second part, which I think is coming up sometime in the middle of August, we're actually going to do an interpretation of 24-hour comprehensive urine hormone profiles. Many of you who may be on this call are already doing some of that with dried urine from some of the labs that offer it. And we're going to really give you an idea of the differences that are there. But in any case, let's look at the comparison of blood, saliva, and urine. And remember what we're talking about. Here we're talking about hormones in general and steroid hormones in particular. So what are hormones? Well, hormones we know, and this is defined in many ways, but they're chemical messengers. They're secreted directly into the blood, carries them to the various organs and tissues of the body where they exert their various functions. And what are they? Well, there are many. Development and growth, metabolism of food, something we all know very well, sexual function, reproductive growth and health, cognitive function and mood, and of course, maintaining body temperature, thirst, etc. A myriad of different effects. But the presentation today and the next couple of lectures is going to highlight steroid hormones. And those are all derived from cholesterol. And they're secreted, as you see here, from 3 steroid glands: the adrenal cortex, the testes, and the ovaries. And the adrenals, of course, as we know, are the main area where you get the androgens, the glucocorticoids like cortisol, etc. You get DHEA, and of course, adrenaline, noradrenaline, etc. So these various hormones are grouped according to the receptors that they bind on in the various cells. And that will determine where these various types of hormones, the glucocorticoids, the mineralocorticoids, the androgens, the estrogens, the progestogens, where do they attack? What do they attach to in the various cells? And so when you're looking at that, you really need to know, how can you accurately assess, in this case, what we're going to be focusing on, which are the sex and adrenal hormones. Which analytical method, which medium should be used, which is, quote, best. And if you're looking at the word best, what are the questions that you're trying to answer? What does best really mean? Best may be different things for different situations. Well, we do know that there are 2 major ways in which you measure or assay hormone levels. Very well known, all of these. One is the immunochemical way, RIAs, ELISA, which many of you may be familiar with as an acronym, FIAs, which is fluorescence, and RIA, of course, is using various types of radioisotopes, etc. The second way is wonderful. It's gas or liquid chromatography. It's a technology that's combined with mass spectrometry. And those 2 together, which is normally called GCMS or LCMS, is going to give you extremely accurate ideas of what is going on with the various analytes. The immunoassays, which are used every day, and we use it in our lab for some of the tests that we offer you. And what we do in using this is that we're using antibodies as reagents, and in that way we can quantitate specific analytes. So you have the antibody, which is attached to the plate, and it picks up these little green things here. These are the target analytes, and there is a particular substrate or a conjugate that attaches to these analytes, and you measure this little thing in yellow. You measure the various conjugates of all kinds of different ones. You do it with radio labeling, enzyme labeling, fluorescence, etc. And in that way, you can get some pretty accurate values. It is used for some hormones, but it is not the best way to do hormone analysis. Really, the best way today is to use the GC or LC-MS. And the basic principle of that is quite straightforward. Either the gas or the liquid is there. You place whatever the analytes are that you want, and it gets separated in these various GC or LC columns. I'm not going to go into it in detail, into ionic forms. And then from there, it is pushed into a mass spectrometer. And that MS unit generates a spectrum which looks something like this, where each compound gives you a molecular fingerprint, which is extremely accurate. And so this is what is used for the urine analysis that we're going to be discussing, specifically GCMS, which is the gas and MS. So when you're looking at steroid testing in different body fluids, there are two basic ones. There's endogenous, meaning it's produced in the body. So all three of the main body fluids, either serum, plasma, and DBS, what we call blood in its various forms, or saliva, that's number 2, or urine, wet or dry, that would be number 3. They can all monitor endogenous steroids, especially the primary steroids, like cortisol, testosterone. Those are called the primary active steroid hormones. And there are issues of accuracy with the various ones. I'm not going to go into various details on that. But testing endogenous sex hormones in serum, it's very well characterized in the medical literature, extremely so, thousands of studies. It's less so when you start looking at urine, saliva, and capillary whole blood, also called dried blood spot, which we use, as you know, in some of our tests for you from our lab. Exogenous means steroids that are being given from outside the body, like hormone replacement therapy. And some of these three fluids that we just discussed are really not appropriate for the measurement of exogenously delivered steroid hormones. Specifically, and we'll go into more detail in a moment, those that are delivered by the oral route or by the topical route on the skin. You got to be careful because these various ways of testing for it can give you some pretty different results. So let's look at blood or serum, first of all, in a consideration of the relative merits of these primary analytical mediums. Well, in the case of blood, we know that you can pick up a lot of different analytes, that's for sure. But what you're doing is you're picking up both the free steroid and the steroid that immediately gets bound up with other proteins, specifically albumin, which is a non-specific protein binder of many different proteins. And you have the sex hormones, which are specifically estrogen and androgens, which are bound up with what's called the sex hormone binding globulin, the SHBG. And then, of course, there's another one. There's the CBG, which is the cortisol binding globulin, and it's also used for progesterone. So you need to remember that in blood, you're picking up both the free and the bound steroids. So very quickly, what are the advantages of testing in blood, specifically serum? Well, it's readily available. Go to any hospital, any clinic, you can get it. It's relatively cost effective because there's so much of it being done. It's widely utilized, quite accepted, very established reference ranges, definitely, that's used in thousands and thousands of hospitals. It does also measure these binding globulins that bind up the steroids, if that's what you're looking for. And it's suitable for testing peptide hormones. That's to be differentiated from steroid hormones. And for example, prolactin, TSH, FSH, luteinizing hormone, LH. And by the way, those hormones, due to their high molecular weight, they don't appear in the filtrates from saliva or urine. You can only pick them up in blood. And as an added feature, a lot of these tests are reimbursable by insurance, which is important for many patients and healthcare professionals. But what are the disadvantages? Well, it provides a snapshot in time. It's a spot test. Hormone levels are time dependent. We know that. And it could have ultradian, that means many different cycles during the day, circadian, which is a 24-hour cycle, diurnal, which is a cycle starting from high to low during the day. So many different types of cycles that you're not picking up with a spot test because they are pulsatile. So that every second, every minute, that secretion changes. And so it creates major fluctuations, especially folks with sex hormones. It also has a very short half-life. And so there's rapid clearance and compartmentalization in different parts of the body. So you've got to be lucky that you're picking it up with a spot test. And the chances are you're not. And the specificity for that is often very poor if you're doing some of those immunologically based assays like the ELISA, RIA, and so on. It's very invasive if you're looking for that kind of collection, especially if you're doing it many times a day. In fact, you don't want to do that. And a full hormone profile during the day, besides being very invasive, is cost prohibitive. So you also don't get a distinction between the bound and the free hormone fractions, which for many healthcare professionals is extremely important to know. And so when you're looking at those challenges for serum testing, especially with oral hormone delivery, if you're looking at bioidentical hormone replacement for estrogens and for the progestogens like progesterone and androgens, etc., all of those are using, for the most part, oral forms of HRT. And you need to know that when you're doing it exogenously, when you're giving these, you need to give 10 times, in many cases, 10 times the physiological dose. And you need that to achieve a physiological level of the active hormone. So it can cause extremely false high hormone levels in serum, especially progesterone. And so you need to be careful. Most commercial serum immunoassays that are relying on antibodies very much overestimate the true levels, especially for women using oral progesterone therapy. You got to be very careful of that. So it has a limited utility for sex hormones. Why? Because if you're using serum, you're not distinguishing between bound and free hormones, etc. And it's testing really just for the total hormones, estradiol, estrone, estriol, etc. The free hormone assays are really not being shown, and it leads to very misleading results. The hormone levels can appear normal. They can even be at high normal because of an abundance of the bound type of the hormone. However, if the free hormone level is low, the patient can functionally be deficient because they're not able to get enough free hormone, even though it looks like they're normal because most of the hormone is bound up. So you need to be very careful with that. I'm not going to go into what it tests. We know all about that, the estrogens, progesterone, etc. We can go over that at a later time. Testosterone, interestingly enough, is an exception when it comes to serum. It is commonly available as both total and free, and therefore it can be useful as a serum testing modality for assessing hormone balance. So serum hormone testing does not measure estrogen, androgen, adrenal metabolites. Those are the products, the breakdown products of all of these primary hormones that I just mentioned. And that is an extremely important thing that you want to know, because metabolites will assist you in understanding a patient's condition, and it'll help to guide you with treatment options. And that leads us, of course, to what's going to be important with urine. Let's take a look at saliva, because saliva has certain advantages. Number one, very rapid testing. It's very accurate in measuring a lot of very validated biomarkers, of which there are hundreds now, has very well established reference ranges. It's by definition non-invasive, very low infection rates. It measures the free hormone fraction. That's what it does. And it's therefore ideal for multiple or serial sampling which we're going to go into in a few moments, much more versatile than serum for evaluating unsupplemented hormone status. And of course, it is accessible to many practitioners, many of those without a license, to order a blood test, which is something that we need to keep in mind. The disadvantages are myriad. Production can be difficult for some patients. Some of them when they're eating, it's difficult when they're drinking, gum chewing, makeup use because lipstick can get into the saliva. If you have inadequate volume, especially when you're over the age of 40, many women who have Sjogren's syndrome, which is a lack of saliva coming from the salivary glands, etc., that can cause a major problem in getting enough saliva. And micro damage from toothbrushing, especially if you brush your teeth less than an hour before you do the testing. It might not even show bleeding signs, but you can have some in there. And it doesn't measure hormone metabolites. Very important. It decreases sensitivity and specificity for some of these analytes because we see them in such small concentrations in saliva relative to serum. And the collection itself, if not done properly, can significantly alter the concentration of the hormones. But what do we see? We do see that unlike blood, which has the bound and free steroids, in saliva, you're picking up the free steroids, which pick up about 2 or 3% of the total amount of the steroid, because it's passing through the salivary gland, and by passive diffusion or by active transport, only the small molecular weight steroids can get in, and that's what you're able to pick up in saliva. So remember then, in the bloodstream, endogenously or exogenously produced hormones, 97 or 98% of the active hormone is bound up, but 2 or 3% is released into the capillary beds, etc. In saliva, most of the metabolites from oral hormone therapy are filtered out by the salivary glands. Only the active hormone enters. So because of that, because of this filtering out, salivary hormones are much more representative of the amount of bioactive, and we're going to use that word a lot, of the bioactive steroid that is present in the bloodstream, and its bioavailability to target tissues, which is really what you want to know from a clinical standpoint. You don't want to know the total amount of steroid. You want to know how much of that bioactive amount is available. We do know that sex hormones will change their levels throughout life, and from a very, very young age, right through reproductive age into postmenopause, you will see some very, very big changes in both the female and male sex hormones. And we know the classic female sex hormones during the menstrual cycle. Remember, there's a follicular phase with a development of the follicle going to the mid-period around day 14 and a classic 28-day cycle where there's ovulation over several days. And then you get to the luteal phase with the ripening of the corpus luteum, leading at the end of that 28 period to the menstruation. And remember that around day 21, 2, or 3, that is when you have the highest levels of progesterone, which is the main sex hormone during the luteal phase. It prepares the ripening of the corpus luteum, the egg sitting in that luteal area. And of course, there's also a secondary bounce of estrogen, which has its highest amount in the follicular phase. We're not going into this in detail, but you need to be aware of it. Saliva, to cut to the chase, is the best way to test for diurnal changes in cortisol. It is by far the best way to do it. Better than serum, better than urine, so that you're able to look at what happens from the morning through to the evening level of cortisol. Extremely important. It's a key to evaluating the HPA axis And you normally start sampling about 30 minutes after you wake and before you start brushing your teeth, etc. And allows the cortisol to come from where it is when you initially wake up to the serum peak in the morning. And that's called CAR, which is the cortisol awakening response. And I want to just put a caveat here. CAR is a very interesting thing to look at from a scientific and from an in-house research standpoint, because in order to get reliable measurements, those samples need to be collected in a controlled fashion. And I will submit to you that when a patient or a client is doing it in their home, their ability to follow those instructions properly and do everything they need to every 5 or 10 minutes is extremely suspect. So is CAR an interesting phenomenon? Yes. Is it on a day-to-day basis from a clinical standpoint in the trenches? Is it valuable? Only if it's reliable. Can you assure its reliability? I would submit to you that many studies are now showing no, that you cannot show that reliability. However, we do know that cortisol is a measure, a very clear measure of stress. And when you are stressed, you can look at saliva measurements of both stressed and non-stressed individuals somewhere in the area of 20, 30 minutes or later, and you will see a very different level from the non-stressed to the stressed individuals. We also know that with chronic stress, you will get adrenal hormones that will change going through classic stage 1, 2, and 3, where in stage 1, when you are in very high chronic stress, you will get overstimulation of cortisol. It will respond with a lot of cortisol, but after a while, it goes into a mid-level, a stage 2, where the adrenals are trying their best to keep up with what is an ongoing chronic inflammatory, stressful state, until eventually it cannot keep up anymore. And you go to stage 3, which is a very low, or in some cases leading to a non-responsive adrenal cortex to ongoing stress. You don't want to be in stage 3. And remember that the daily profiles for cycling, for cortisol and melatonin will have a diurnal rhythm. Melatonin, which is in black, has its highest level right in the middle of the night, and then comes down where it's almost at very low levels by the morning, and then stays pretty low until it starts to rise in the evening. Cortisol has its highest level in the morning and then begins its diurnal trip through the day to its lowest level in the evening. And for those of you who do the fluids IQ test, you'll remember that we have the stress and hormone profile. We now have added to that an advanced stress and hormone, which includes testing for insulin in saliva. So it's a very valuable area, but it has its shortcomings. So let's spend the rest of our time looking at urine as the third of the three. And I'm going to tell you that there are many ways to test for all the different pathways. And in my next lecture in August, I'm going to go through this in detail, but this tells you about the biosynthesis and so on of the various steroids and the enzymes that are dealing with it. What you need to be aware of is that when you are looking at metabolism, which is what the urine samples give you, most of that takes place in the liver. And you start with steroids in the blood, most of them in a fat-soluble state, and the liver breaks it down in the classic 2 phases of liver metabolism. The first phase is to break it down with oxidation, reduction, hydrolysis, etc. All kinds of ways of breaking it down. By that point, you have what's called an intermediate metabolite, And then it goes into phase 2, which is neutralization. And that's when you get into the whole idea of sulfation, of glucuronidation, etc. Methylation, which you see with a lot of steroid hormones. That's going to lead to water-soluble derivatives, which get excreted, first into the serum, then into the kidneys, which some people call phase 3, and the kidneys do their magic, which allows you in the urine to look at both the primary hormones and those metabolites, the breakdown products, which were broken down in the liver. And that's important. So when you're doing urine sampling, we know for steroid hormones, remember, we're talking strictly about steroid hormones. It's less common in clinical practice than either serum or saliva, but it's gaining a lot of fans now. Let's say it very clearly, 24-hour urine collection. Everyone, I don't care what the lab is, etc., they will tell you it is the gold standard for testing steroid hormones, especially for those that are secreted at night during deep sleep, etc. It is by far the most economical and reliable way of evaluating hormone metabolites. And in some cases, it's the only way. But you need to differentiate, ladies and gentlemen, from 24-hour, from serial single point collection, which is exemplified, of course, by dried urine sampling, which has been gaining a lot of popularity of late. So what are the advantages of 24-hour urine? Well, it shows the unbound, the bioavailable fraction, just like saliva, but it also gives you the metabolites, which the others don't. It prevents false highs and lows, which is what occurs when you're testing with the spot method, like serum, saliva, and dried urine. We'll call it what it is. That's what they are. They're spot methods. So clinically, if you're doing 24-hour, it correlates very well with very established reference ranges with symptoms on hormone questionnaires. And in that way, it allows you as the clinician to evaluate the adequacy and the safety of various exogenous estrogen supplementations, etc. What are the disadvantages? Well, there is some questionable inconvenience and compliance. There's the ick factor. A lot of people say, ew, I've got to collect my urine. Well, it's not as bad as that, but it is a questionable issue. The results can be affected, I don't care which urine technique, by significant liver or renal impairment, dehydration, keep that in mind, or excessive fluid intake. And that is a fundamental issue with what's called creatinine, which we're going to go into in a few moments. The results can be misinterpreted in some cases due to what's called the hepatic first pass effect. If you're taking oral hormone replacement therapy, it gets into the intestine, gets into the hepatic area of the liver, and gets broken down. So you end up with some false ideas of what the actual concentration of those hormones are. It does not, as I said earlier, elucidate diurnal cortisol rhythm. It just doesn't. For that, you need saliva. What are some of the other advantages of 24-hour urine? Well, we know it measures cortisol and cortisol, which is, cortisol is the storage form of cortisol. It also does the mineralocorticoids, like aldosterone and so on, which are important for fluid management in the body. The metabolites are very important when you're testing them, especially in stressed patients with normal or high normal cortisol. So you want to know what those metabolites are. We're going to go over that in our second lecture. The mineralocorticoids, extremely important, as I said, for regulating salt-water balance, etc. So it provides a more in-depth clinical picture since it measures the hormone metabolites along the various pathways. And that's going to tell you how the primary hormones are being affected by enzymes, cofactors, remember the liver. So you get to know what's going on between the synthesis of the hormones and their eventual elimination. That is extremely important. So urine testing reveals the total hormones that are consumed and eliminated, but not how much of the bioactive and available hormone is present in the systemic circulation. So the conclusion, urine testing is an excellent way to evaluate endogenous, that means produced in the body, production of sex hormones, but it is not the best clinically useful way to be a diagnostic fluid way, or even for streaming and for looking at non-diagnostic fluids for exogenous oral or topical hormone delivery. But let's look at dried urine, because I think that's really what I want to stress today. All samples, when you're doing dried urine, and let me stop for a moment. Remember, Fluids IQ does dried urine. We use it. It's a wonderful technique for non-pulsatile hormones, for hormones that aren't changing every minute. We use it very effectively with good reference ranges that maintain their stability, but not for sex hormones or adrenal hormones, because they're not pulsatile, the other kind, whereas the adrenal hormones in sex are. So the samples for dried urine look at a defined moment in time. So by definition, it's a spot test. And a spot test, that's a snapshot in time, which has fundamental flaws and many compromises, especially when you're comparing it to a full 24-hour production cycle, which is very well understood. So because you're doing dried urine, you're forced to normalize to a breakdown product of creatine phosphate, which comes from muscles and protein metabolism, and it's found in urine, and that entity is called creatinine. And what's creatinine? And I want everyone to understand this, and that's why I'm going to spend a couple of minutes on it. Creatinine is well known. It's tested for every day, tens of thousands, maybe millions of times throughout the world. It's a waste product of muscle metabolism. So it's excreted in the urine at a relatively constant rate, and it's done by glomerular filtration. I'm going to call it GFR, which is relatively stable within an individual, which of course then makes it very attractive for normalizing any other analyte. But it does vary, and varies widely, ladies and gentlemen, with age, with race, with diet, with gender, with weight, with genetics, with hydration. Remember that last one. So if you're looking at something called the glomerular filtration rate, the GFR, it is known, very well known, and tested for, as I said, every day. It's the best way to determine normal kidney function. That's why we do it. So you do a 24-hour urine creatinine clearance, CRCL, extremely well known, and you multiply the ratio of the creatinine in the urine to the creatinine in plasma, that ratio, you multiply that by 24-hour urine volume. And when you do that, you end up with a GFR. And you need to normalize creatinine. So what you really need to do is any analyte that you're measuring with a spot test, you divide the concentration of that analyte, let's say estrogen, from the sample in urine, and you divide it by the creatinine level in urine, and that's going to give you a value. Well, you say, okay, that's great. Well, it's not so great, because ideally, what you want to know is how much hormone was produced in the classic microgram per 24 hours. And that is a way of eliminating all of this urine volume variability within day to day, etc. Well, instead, with a spot test, you're forced to normalize, as I said, to creatinine. And that's a fundamental problem, as we said a few moments ago, for pulsatile analytes. And so for all these reasons where it can vary, the subject ends up as their own control. And it can't be classified with a typical reference range. And sure enough, what do we find? That the reference ranges which are quoted for spot urine samples span an order of magnitude. You're ready for this? A factor of 10. And by the way, if you look at all the different labs, I'm not mentioning any labs. There are a whole bunch of labs that have jumped on the dried urine analysis. And if you really start looking at their reference ranges, and if they're being very forthright, it has a very high range, almost to a point where it's not useful at all, to say the least. In contrast, the reference range span for a 24-hour urine sample lies in what you normally expect, which is a factor of 2 to 3. So creatinine production is assumed to parallel steroid hormone output. It's never been adequately addressed in the literature. And I defy anyone to show me a bunch of studies because they don't exist. So almost no labs that are using dried urine spot test have published their methodologies, or more importantly, ladies and gentlemen, have had them confirmed by independent validation. So for example, if you take results from split samples, in other words, you send a sample to one lab, send the same sample from that same individual to another lab to see what they come up with. And when you do that, and it's been done, by the way, many, many times, and those samples have differed by greater than 3 orders of magnitude. And that's both for labs that are utilizing dried urine, and they do it for 2 samples, or they sample dried urine versus 24-hour urine. The results are completely different, 2 different planets. So we've got to say, you have to look yourself in the mirror and you have to say, okay, spot creatinine levels, number one, are unacceptable compromises for pulsatile hormones. And by the way, I'm just a messenger. I'm not telling you this because I thought it up. That's just what everybody knows or should know. So serious methodological concerns exist with spot urine paradigms. What are they? Well, there is one, which is adequacy and reproducibility of steroid extraction from dried paper substrate. No matter what you're going to be told, there's an issue with some of the papers being used where you actually put the urine and let it dry. There's the adequacy of what's called derivatization. And I'm not a specialist in GCMS, but derivatization, when you speak to the specialists, they tear their hair out. I'm almost bald, so I don't do that. But it's a way in which an analyte properties can be changed for better separation in a GCMS system. And it's extremely important in a protocol for steroids that have ketone functional groups. It's affected by diet in terms of the extraction efficiency. And I would tell you, most importantly, it's affected by hydration. How much fluid intake has come in? You can either have too low a level of creatinine, which every lab will send a message that you'll see on the report saying, we're basing this on the fact that the creatinine is high enough for any of these analytes to make any sense. But what about the people who are taking too much fluid? Those people who are interested in sports, who are very much interested in taking in a lot of fluids. It's a great idea. But when you do that, that hydration changes dramatically the creatinine concentration, and therefore, ladies and gentlemen, changes what you're getting with the results that are being published in a report. So those urine compositions may differ profoundly based on what precedes them in any kind of a snapshot or point in time collection. So I have to say that in absence of independently published methods and data, and given the small, really limited urine volume in a dried urine sample for this type of analysis, it is unclear how quantitation of certain analytes, we're talking here about the steroid hormones, can be credibly accomplished and reproduced. Reproducibility, you got to be able to do it one day after another, whether it can be reproduced with confidence. And I would submit to you humbly that the dried urine paradigm is arguably outside acceptable scientific standards. But there are standards, and we've known this for decades. Here's something from Shackleton in 1985. I could show you many others. What are the requirements for accurate urine steroid profiling? This isn't new. This is as old as the hills. You want to get a good quantitization? Collect 24-hour quantitative extraction of all the conjugates, which would make it difficult to use urine. Get complete hydrolysis of those conjugates, which you can do, but you've got to do it right. Quantitate the recovery of free steroids. Quantitate the conversion of all the steroids into volatile derivatives in a GCMS system. Otherwise, you're not getting proper results. And reproducibility of inter and intra assays for individual steroids. I want to see that. Every good scientist says, show it to me. They're not showing it. So, and I can show you many studies that do go into GCMS and LCMS. It's thousands of these studies. The literature has many peer-reviewed articles that compare GCMS to LCMS for 24-hour urine samples. It's the gold standard. Everybody knows that. By the way, including, as I said, the labs that are also doing dried urine, because many of them do 24-hour urine. There are no independent studies that I am aware of, and many of the people who are scientifically committed to this whole area, that compare and contrast 24-hour to dried urine spot sampling. So if you want to do the most complete assessment of hormone function and to know that you're getting it right, what do? This is not rocket science, folks. Ideal combination of tests. What do you do in urine? 24-hour. Saliva for adrenal function, for 4-point cortisol, otherwise known as diurnal. Well known. By the way, even the labs that are doing dried urine are now saying, and we add saliva to it, because they know. And even DHEA, good screen in saliva. Serum, a lot of stuff in serum. Thyroid panels, FSH, LSH, whatever your doctor is asking you to do when he sends you for various blood tests, CBC, serum iron, total iron binding capacity, etc. A1C, the list is endless. Each has its set of clinical strengths and limitations. And it's really a combination of methods that make it appropriate. There's not one size fits all. Remember, blood tests for total steroid, tests for 97 or 98% of the steroids, but it's mostly bound up. Saliva, the free steroid, the 2 or 3%. Urine, what is the most important? Because remember, urine is what the body discards. So not only is it some of the primary hormone, but it's also showing you the discarded metabolites. And that is extremely important. This is a very interesting graph and table, that came from Sava, runs one of the very good labs in North America. And it shows you all the appropriate body fluids for testing exogenously delivered hormones. And his message, which you can go to in detail if you want me to send this to you, he says saliva and dried blood spot, not serum or plasma or urine, are the only ways to accurately monitor exogenous topical steroid hormone therapies. So remember, whatever you're going to be utilizing as a methodology for testing, you need to do your homework, because what may be good in saliva is not good in blood, and vice versa. It doesn't make either one of them bad. You need to choose the right tool for the job. So, comparing fluid mediums for endogenous hormones, all 3 body fluids are good for endogenous. And for exogenous, serum for accurate oral administration of sex hormones will need extraction and separation of metabolites. So be careful. Urine, it's not recommended unless the range is reestablished for dosing, etc. which you can get with 24-hour urine. Serum and plasma and urine are not recommended for testing steroid hormones, which are delivered by topical route, as I said just a few moments ago. What is best? Saliva. How about that? Very interesting. And we have a whole bunch of references, and I can give you references till the cows come home. And so that is the end of the initial, or part one, which is going to set the stage for what we're going to be discussing in August, which is a very large discussion of the interpretation of 24-hour urine.